also looking at health policy issues. And she got her start working as a legislative aide for Carl Levin back when the world was lit by fire. But she's pursued a consistent course in health policy, and has been a tremendous asset to neurosurgery in terms of teaching us how things work and what things mean in DC. And today she's going to talk to us a little bit about alternative payment models, which is something that's been talked about over the last really 10 years and has finally come into fruition and has had actually significant impact upon the organization of UW. And with that, I'll shut up and let Rachel get started.
Thanks for the introduction. Like Dan said, I was asked to talk about the future of alternative payment models. So my presentation is going to start with talking about some of the pressures on the healthcare system that have led to the introduction and evolution of alternative payment models. I'll then get into some of the different types of models being tested by the federal government. And then I'll discuss where APMs are headed and some of the challenges that remain. I just wanted to mention that I have nothing to disclose. So as you all know, in healthcare, there's really no topic that's drawn more attention among policymakers and providers and payers than healthcare spending. So I just wanted to go through some of the sort of what's going on in terms of healthcare spending and rising healthcare costs. National healthcare spending reached almost $4 trillion in 2019, or 17% of the GDP. Hospital expenditures specifically grew a little over 6% to $1.2 trillion in 2019, which was faster than 2018. Physician and clinical services expenditures related to those grew a little slower, 4.6% to $772 billion in 2019. And you can see in the pie chart that really hospital care is the biggest contributor, followed by physician services. And you can see some of the other categories as well. Overall, spending is projected to increase a little over 5% annually through 2028, outpacing the GDP's average annual growth rate of 4.3%. By 2028, healthcare spending is expected to reach $6.19 trillion, which is roughly $18,000 a person, and will account for almost 20% of the GDP, which you can see here on the right. So what's contributing to these rising healthcare costs? As you all know, healthcare spending is generally thought of, it's a function of price and utilization. There are a few notable drivers of increases in both of these factors, namely rapidly aging population and rising healthcare prices. So in terms of the population growth and aging population, in 2018, individuals 65 and over accounted for 16% of the population, but that's projected to exceed 20% by 2030. The number of Medicare enrollees is expected to increase from 60 million to 75 million by 2028. Medicare spending reached $800 billion in 2019 and is expected to grow an average annual rate of 7.6% from 2019 to 2028. So it will have the fastest growth rate among the major payers. Commercial payers, on the other hand, are expected to see a more modest average annual growth rate of 4.8% from 2024 to 2028. Medicare spending is projected to double over the next 30 years relative to the size of the economy, growing from 3% of GDP to 6% by 2049. And the government is projected to pay nearly half of the nation's total health bill by 2028. As baby boomers age into Medicare, they'll consume $1 out of $4 spent on healthcare. These are just some graphics showing the share of people age 65 and older, how it's projected to increase over the next 10 years, and how Medicare spending as a percent of GDP is also expected to grow pretty substantially. So price growth is also a significant driver of healthcare spending. Over the past 20 years, the Consumer Price Index has grown annually at an average rate of 2.1%, while the Consumer Price Index for medical care has grown at an average rate of 3.5% per year. and it's projected to accelerate over the next decade. So in terms of a few times in this presentation, I'm going to talk about the impact of COVID, but in terms of the impact of COVID on healthcare utilization and costs, the data is sort of mixed. So, and I think it's because the data is still coming in. On one hand, there's data showing that hospital admissions remain below expected levels through early April 2021. And this sort of signals that thus far into the pandemic, we might not be seeing an increase in hospital admissions due to what is thought of as pent-up demand for foregone care in the last year. And as a result of these lower utilization levels, health services spending, which here in this graphic includes hospitals and ambulatory care, it also remains 7% below expected healthcare spending in June 2021. So these lower than expected utilization and spending numbers suggest that some of the care that didn't occur early in the pandemic was perhaps foregone rather than simply delayed. This could potentially be due to various factors, economic reasons. Maybe the pandemic is causing people to forego care for cost reasons. There's definitely a limited supply of healthcare workers in some geographic regions that may be leading to continued delays in the availability of care. Some of the care that was missed early in the pandemic may have been for acute conditions that might have resolved on their own, or chronic conditions that were managed with less service intensity than otherwise would have occurred. And then in other cases, there were just missed care that may have led to worsened outcomes and even premature death. There is concern that deferred care could affect providers' bottom lines. Despite the lower levels of utilization and reduced spending, providers are temporarily sustained right now by federal assistance related to the pandemic, including $178 billion that is currently being distributed from the Provider Relief Fund. So it's sort of hard to see the impact right now. But over the long run, there's speculation that once federal assistance dries up, some of this depressed utilization could affect finances of hospitals and other providers. Health insurers, in contrast, seem to be benefiting from this decline in utilization. In 2020, average gross margins for health insurers remain relatively high compared to the previous years across their various markets. But like I said, the data is sort of mixed and still coming in. There have also been recent reports of health systems that have actually strengthened their financial footing in 2021 and early 2021. So as you can see here, there are some systems, many of which are in the Midwest, that have actually boosted their operating margins in the first quarter of 2021, almost by 10%. And this is a pretty significant shift when you look at sort of what had been a challenging 2020. So, you know, it's unclear. Some of this positive performance, like I said, might be due to ongoing federal assistance that these hospitals are receiving related to the pandemic. But it does seem to be, at least right now, more driven by returns to volume and pent-up demands in certain markets. Interestingly, the Medicare trustees report, which the 2021 report just came out in August, found that COVID did not substantially affect when Medicare's hospital insurance trust fund will be insolvent. It's still projected to be 2026. Medicare was dramatically affected by the pandemic. Payroll taxes decreased. The cost for testing and treatment of COVID went up, and there were regulatory provisions that definitely increased program costs. But spending for non-COVID care declined so much compared to 2019 spending and 2020 expectations that it happened to more than offset the additional pandemic costs for last year. An unusually high degree of uncertainty. There's an unusually high degree of uncertainty surrounding the impact of the pandemic, as I alluded to in my previous slide. Return of deferred care may occur in 2022. We might see more intensive services and higher costs than previously estimated. There are also sort of new ways of providing care, telemedicine and other alternative delivery models that may alter how people use care going forward and may impact the numbers. So prior to the pandemic, policymakers over the last 10 years or so have really been trying to reduce the rate of annual health spending through various regulatory initiatives, including the increased use of value-based payments. And value-based payments, as many of you know, aim to address sort of the flawed incentives in the fee-for-service system. They reward better outcomes at lower costs, and they try to avoid unnecessary utilization. So there were two major laws that were passed to accelerate this transition from volume to value. The first was the Affordable Care Act in 2010. Most notably, it created the CMS Center for Medicare and Medicaid Innovation, or CMMI. This center was created to support the development and testing of innovative healthcare payment and service delivery models. I'll review some of these in a minute, but wanted to highlight that they also test not just payment models, but alternative delivery models. They, over the last few years, have tested a program, for example, that aimed to improve care transitions from the hospitals and other settings, that also aim to reduce readmissions for high-risk Medicare beneficiaries. There's also the Affordable Care Act also authorized the Medicare Shared Savings Program. When you think of accountable care organizations, most of them are being carried out through this program, although some are also being tested through CMMI, as I'll talk about in a minute. But the Medicare Shared Savings Program is the largest Medicare ACO initiative. The Affordable Care Act also created programs such as the Hospital Readmissions Reduction Program and other sort of quality reporting programs in different settings. And it also extended a temporary demonstration project that allows hospitals to provide gain-sharing payments to physicians when it represents a share of savings that they incur as a result of one of these sort of value-driven initiatives. So it gave them some more flexibility. Then in 2015, Congress passed legislation known as MACRA, which authorized programs that aim to change the way that Medicare rewards clinicians for value over volume. These programs include the Quality Payment Program, which includes the Merit-Based Incentive Payment System, or MIPS, as well as other Medicare incentive payments to physicians who participate sufficiently in risk-based alternative payment models. And then finally, MACRA also created the Physician-Focused Payment Model Technical Advisory Committee, or PTAC. And this established a panel to incentivize the development of physician-focused APMs with, I'd say, I'm not going to get into the details of this, but PTAC has had some mixed success over the years. The pieces of legislation really, the pieces in the legislation in the previous slide really stimulated the development and testing of alternative payment models, as well as provider movement towards APMs. On the federal side, CMMI has really expansive authority to create and test payment and delivery models without congressional approval. There are some requirements. Models are required to improve quality without increasing spending. They have to reduce spending without reducing quality, or they have to improve quality and reduce spending. And if they don't meet any of these goals, they have to be ended or modified. Over the last 10 years, CMMI has tested more than 50 alternative payment models. They're currently operating a little over, I think, 10 APMs right now, but they offer about 25 different distinct tracks for providers to choose from that involve different payment options and risk arrangements. And then, while I'm focusing on the sort of what's going on through Medicare and federally organized APMs, I did also want to note that there are obviously private payers are obviously also testing their own APMs as well. So just a quick overview of the different types of APMs. APMs can all vary in design, but they all seek to restructure payments to providers in a way that financially incents low-cost, high-value care. They generally fall into 3 or 4 main buckets. The first is total cost of care models, and these include the Medicare Shared Savings ACOs, next generation ACOs, which I'll talk about, and a newer direct contracting model, which I'll talk about in a minute. Participants are accountable for cost and quality of care for a target or target patient population. A benchmark is established based on historical spending. Beneficiaries are aligned to participants based on specific criteria. I'd say in most of the models to date, it usually has to do with the plurality of primary care visits. And then payment mechanisms can vary in these models. They can continue to be paid under fee-for-service, and then payments are reconciled against a benchmark after the fact or even before the fact. They can receive capitated payments instead of fee-for-service, which is rare. Most of these are still built on fee-for-service. Or what we're seeing most popularly is sort of a combination of both a reduction in fee-for-service claims as well as capitated payment. And then importantly, participants can achieve shared savings if expenditures are lower than benchmarks. But there are also downside risk models where spending exceeds a benchmark, the participant is required to repay Medicare the difference. And then in the middle here, we have episode-based payments, the second category. These are generally what we consider bundled payments for care, but there are also more specific models like the comprehensive care for joint replacement and oncology models. Participants are accountable for the cost and quality of care that beneficiaries receive during a specific episode of care. And depending on the model, the episodes can differ in terms of their clinical service that they capture. Some include inpatient hospitalizations only. Some look across inpatient and outpatient services. Some just focus on post-acute care services. So there's a range of models. Episodes usually are initiated by an event such as the hospitalization, and then they're extended for a certain amount of time, so just 90 days. A target price is established for a defined set of services and items that are received during the episode. And then again, payment mechanisms can vary. Participants can continue to be paid under fee-for-service with a reconciliation against the target price, or receive a set target price instead of fee-for-service claims. And again, participants can receive positive reconciliation payment if their expenditures are lower than the target price for the episode, but they also may owe CMS money back if spending exceeds target prices. And then finally, on the right side, there are other models that focus more on sort of primary care transformations, strengthening and increasing access to primary care. They sometimes include an increased payment to providers to cover investments in infrastructure or increased costs related to care coordination. These are either standalone models or they may be sort of layered on top of some of the other models. So the Healthcare Payment Learning and Action Network, otherwise known as the LAN, is a group of public and private healthcare stakeholders that convened in 2015. They have a mission of increasing the percentage of U.S. healthcare payments that are tied to quality and value through alternative payment models. And as part of their effort, they measure nationwide progress towards APM adoption. Their most current report, which includes an analysis of all payer data covering about 77% of the national market in 2018, is displayed here. And it shows that you can see in category 1 up top, only 39% of healthcare payments made in 2018 were through a fee-for-service structure that had absolutely no link to quality or value. If you look at category 2, about 25% of healthcare payments in 2018 were fee-for-service tied to some element of value and quality. And then categories 3 and 4, about 36% were tied to some kind of bundled payment model, shared savings model, or a population-based payment model that relied on, that was either built on fee-for-service or relied on population-based payments. So I'm just going to take a few minutes to talk about some of the more well-known models. As I mentioned, the Medicare Shared Savings Program is the largest of Medicare's ACO programs. Currently, there are 477 ACOs participating in the program, and they serve about almost 11 million Medicare beneficiaries. Participation in the program since it started initially grew pretty fast, but then it faltered. Some of this was due to the fact that there were Trump-era policies that were implemented, known as the Pathways to Success, that required over the last few years that ACOs take on financial risk earlier, and that they cut their shared, that CMS cut their shared savings. This was really in reaction to concern that most of ACOs were participating in upside-only risk tracks, so they weren't taking enough risk, and the program, as a result, wasn't saving CMS money. There were some temporary flexibilities afforded to ACOs during the public health emergency that are currently still in effect, that do allow for their, it allows them to not transition to these higher risk models so quickly. They can remain at their current levels of risk for an extra year. And there are other policies that mitigate potential for losses. But generally, this Pathways to Success movement sort of had caused a lot of pushback from the ACO community and caused the number of participants in the ACO program to drop suddenly. In terms of results from the program, in 2019, the program produced the largest annual savings to date. It produced $1.2 billion in net Medicare savings compared to much lower savings in 2018 and 2017. In terms of data, ACOs under the Pathways to Success seem to be performing better than their legacy ACOs. ACOs that took on downside financial risk seem to be outperforming ACOs that did not in terms of savings. Low revenue ACOs, so those that are led by physicians and mostly provide outpatient services, generally save more than high revenue ACOs that are led by hospitals that provide inpatient and outpatient services. Urban ACOs tend to outperform rural, and ACOs outperformed fee-for-service providers on most quality measures and improved quality over time. And you can see here, this shows gross federal savings. Medicare ACO performance, you can see improved each year since it started in 2012, with gross savings totaling more than $7 billion. And obviously, when I'm talking about success and performance here, we're talking about spending. While there is some evidence that quality has improved, that evidence is not very strong. And as I'll talk about towards the end of the presentation, there's questions about whether these models are even measuring the right things when it comes to quality. Ongoing challenges related to ACOs. It's challenging to align hospital financial incentives with those of ACOs. As you all know, few hospitals operate off of global payments. Revenue is really based on heads and beds. Most ACOs still have a foundation of fee-for-service payment, which may limit sort of their impact. ACOs that save money are subject to increasingly lower benchmarks. So sometimes these, not just ACOs, but even other models, they're not sustainable over time. The better you do, sort of the harder it is to continue on in the program. In the ACO program, the Medicare Shared Savings Program, there's no incentive to manage Part D drug costs at a time when these costs are increasing. And also, Medicare beneficiaries don't really understand what ACOs are, and they don't really feel a need to maintain a relationship with their ACO provider, as they may when, if they're in like an in-network Medicare Advantage program, and they sort of want to stay with their in-network providers. There are also more innovative ACO models that are being tested outside of the Medicare Shared Savings Program through the CMMI. Most notably is the Next Generation ACO program, which launched in 2016. I wanted to highlight this one because I believe this is the one that UW participates in. There are currently 35 Next Gen ACOs. They are required to take on more financial risk than the Medicare Shared Savings Program ACO. So under the Next Gen model, participants have a choice between 80% or 100% risk compared to 75% under Shared Savings Program. In May, CMS decided not to extend the model. They found that the program did not have a statistically significant impact on spending. There were some critics felt that this finding was flawed, since CMS was comparing next-gen spending to shared savings program spending, which did not require as much financial risk. They were hoping that CMS would instead count next-gen spending against traditional fee-for-service spending to show the positive impact. But anyway, CMS, and this all sort of recently happened, but CMS encouraged all these next generation ACOs to apply at the 11th hour for what's known as the global and professional direct contracting model in 2022. But as I'll talk about in a second, CMS sort of simultaneously hit the pause button on this direct contracting model. So it's really only open to these next gen ACOs transitioning right now, or that have already applied. But the overall point here is that organizations such as, including, I'm sure UW, sort of had to make a last minute decision about whether they wanted to remain, whether they wanted to transition to this new direct contracting model. And it's a model that obviously has already raised some red flags among stakeholders. So I'm not quite sure what UW decided to do. Perhaps we could talk about that at the end of the presentation. A quick word about this new direct contracting model. It's basically a global payment model that provides direct contracting entities with a monthly per beneficiary payment. It builds on lessons from both the shared savings program and next gen model. It also draws on some ideas from Medicare Advantage and private risk sharing arrangements. What makes it a little more unique is its flexibility. These direct contracting entities may select between multiple payment options. They can do partial or total capitation, as well as different risk sharing arrangements, 50 or 100% of shared savings and losses. They also, interestingly, can have sort of different relationships with their physicians. So what we're seeing is, the bulk of them will have a fixed per member per month fee that they give to primary care. So it's more like an ACO. But for their specialty practices, they can have more of like an episode-based contract. So there's flexibility depending on the physicians that are in the model. It is more of a departure from previous models in that that still rely on underlying fee-for-service payments, since it's moving towards total capitation. But like I said, after selecting participants for 2021, CMS has paused this model for 2022. There were various concerns. Actually, one of the most vocal opponents of this was our U.S. Representative Mark Pocan, who urged CMI. He sent CMMI a letter with some other legislators asking them to pause the model beyond 2022. He was concerned that the model could result in auto enrollment of traditional Medicare beneficiaries and Medicare Advantage plans, which would sort of take away patient choice and potentially increase costs without any value. Other stakeholders that have been critical are urging CMS to potentially create a new pathway that's sort of between the next gen and the direct contracting full capitation option. So that remains to be seen what's going to happen there. You're also probably familiar with the Bundled Payments for Care Improvement Initiative. This is a voluntary retrospective bundled payment program where CMS pays a fixed price for each episode. Episodes start with initial hospital admission or outpatient procedure and include almost all services during the next 90 days. Participants are still paid under fee-for-service, but payments are adjusted to meet a target price. As I mentioned earlier, participants can earn a reconciliation payment if their episodes are below a target price, but they also might have to repay Medicare if their payments are above a target price. There is an element of quality metrics, so there are adjustments for how you do on quality. Initially, the program included about 30 episodes that providers could choose from. Some related to neurosurgery are listed here. You can see they fall into inpatient and outpatient categories. But more recently, CMS, because the program was not saving money and was complex and they weren't getting enough numbers in each of the episodes. They decided to consolidate all episodes into service line groups. So you can no longer opt into just one clinical episode. You have to opt into a service line to participate, but adjustments are still made to the specific episodes within the service line. One of the biggest challenges related to the BPCI program to date has been its impact on net Medicare spending. A recent RAND study, as you can see here, net Medicare spending related to the program, there was $158 million estimated net loss, and you can see here some of the impact for some of the specific episodes, how much loss it caused to the Medicare program. I will say there was some recent RAND data that showed that bundled payment models did lower costs in the commercial market, but I think overall the consensus is that this model is challenging in terms of bringing costs down. So other challenges related to this model, the episode bundled payments, they do promote efficient care, but the episodes are often too short for long-term specialist engagement that meets sort of the whole need of the patient. Cutting costs with bundling is not so simple for more complex procedures and conditions. There's only so much, as I mentioned, even related to ACOs, there's only so much participants can cut costs before it's no longer worth participating. That's been a major challenge with this program. There have also been concerns about it being voluntary and clinicians self-selecting episodes they know they're going to do well on. Participation, there was a drop in participants in 2019, but the numbers seem to pick up again. CMS did make some recent changes to the model for 2021 to improve its financial sustainability. So we'll have to sort of watch what happens, but CMS has indicated that they are very interested in making this potentially a mandatory model. It's unclear at this point how they would apply that. It might be in certain geographic regions, but stay tuned for that. There's a good chance this could become mandatory. Looking ahead to the future, the last part of my presentation, I mentioned the LAN before, and that they have a shared goal of accelerating the percentage of healthcare payments that are tied to quality and value, particularly through the adoption of two-sided risk models, so models that have downside risk. You can see here they have a goal of all 100% of Medicare transitioning to full risk models by 2025. They have a goal of 50% of the commercial market transitioning to these models. So there's definitely a trend, or at least a hope, that payment systems and models will move towards value-based, risk-based payments. MedPAC, which is an independent panel that provides guidance to Congress on Medicare payment issues, recently came out with its June report that said current APMs have had limited success. They were pretty critical of the large number of APMs and said that CMS should reduce the number of APMs, that there are just too many APMs out there. They specifically said that CMS should implement a more harmonized portfolio designed to work together to support the strategic objectives of reducing spending and improving quality. I will say, of the 54 APMs tested in CMMI's history, only 4 have actually met the CMS standards to be expanded into permanent nationwide programs. MedPAC also highlighted that the glut of models, it creates redundancies and confusion. It hinders the evaluator's ability to accurately identify a model's impact. One of the commissioners called it contaminated comparison groups. Also, provider overlap dilutes the effectiveness of models and the financial incentives in other models. There are about currently, or in 2019, there were 580,000 clinicians who participated in at least one Medicare APM, and about 20% of those participated in multiple APMs. So this is a significant problem. While the shift to value-based care definitely has garnered bipartisan support over the years, I'd say each recent administration has taken a slightly different approach to it. Obama's administration was responsible for implementing the first round of these payment models, so getting providers to participate and experiment with new models. Under Trump, we saw an emphasis more on increasing performance and acceleration towards taking more risk. The Trump administration also implemented some requirements related to price transparency. Now with the Biden administration, I'd say we're sort of at a crossroads. The administration is taking a hard look at the lessons learned over the past 10 years, especially now with this MedPAC report coming out. And they're trying to chart a more meaningful path forward. As I noted throughout the presentation, they're even pulling back or delaying on some of their models and sort of hitting the pause button as they evaluate these models. So we expect 2022 to be more of a bridge year and for not many new things to be introduced by CMMI. The new head of CMMI, Liz Fowler, even though they're hitting the pause button, she's made very clear that their commitment to value-based care has never been stronger. She has indicated that they are definitely exploring more mandatory models. They found that voluntary models are harder to generate savings with because of self-selection and things like risk selection. They're definitely interested in exploring models that are not built on a fee-for-service chassis. They are interested in expanding multi-payer partnerships and sort of more alignment between what's going on with the federal APMs and commercial APMs. They want to focus more on outcomes, particularly patient-reported outcomes, equity, and ensuring that these APMs are more patient-centered. And they also acknowledge that there's definitely a need for more transparency and real-time data on the impact of these models on providers and patients. Regardless of the model, there are some general challenges that will definitely stand in the way of APM adoption moving forward, and that will need to be addressed one way or another. One is that the biggest revenue drivers are still highly specialized services that don't necessarily fall neatly into these value-based care programs like complex surgeries. The percentage of revenue that most organizations generate under value-based arrangements is still relatively small. And for now, fee-for-service is still the main way that most providers are paid. Another big issue is that primary care-based models, namely ACOs, seem to lack a clear opportunity for specialty leadership and participation. This has been a big issue, especially for neurosurgery and its colleagues in the Alliance of Specialty Medicine. Other future challenges, I think we really need to improve our definition of value. Are patients involved in APMs actually receiving better care, better quality care? I think we haven't determined that yet. Are we even measuring the right things under these models? They all have a set of metrics, but are they truly meaningful metrics? There's also a major disconnect between what's being measured right now on the cost side and the quality side. They measure what they can in costs, and then they measure whatever they can based on what quality metrics are currently available. But there's often a disconnect there, and they're not really producing an accurate picture of value because of that. Also, federal statute that governs the success of CMMI models is based on whether they reduce costs across the entire system. So this statutory requirement could be a bit limiting, and it may need to be adjusted through congressional intervention. I think also we'll need to improve predictability for providers moving forward. There is consensus that we need to improve risk adjustment for complex patients. We need to better account for social determinants of health and more digestible attribution methods. And like I said, there's an ongoing need for data transparency and access and interoperability. To participate in these programs, providers need timely data from payers. They need data that they can easily integrate with clinical data from registries and EHRs to sort of best measure and predict their outcomes and successfully participate in these models. And then I'll just wrap up, last slide, by noting that the pandemic may have actually shed some light on the future of healthcare in this country in general, but also specifically on the future of value-based payment models. some experts believe that the pandemic further helped support movement towards value-based care, since it exposed some weaknesses in fee-for-service when volumes dry up. Organizations and alternative payment models that were paid through prospective payments during the pandemic rather than based on volume, they had greater financial protection to weather the crisis. And it also illustrated the advantages of being responsible for the whole patient, having data infrastructures that allow for population health management and care coordination. So this might be sort of a preview of our future. I will wrap up with that. Here's my contact information. I don't know if we have time for questions, but if we do, I'll take some. Otherwise, feel free to contact me at this email address.
Rachel, thank you very much for that. It's absolutely essential that the residents and all the faculty understand the language, what's going on. Could you comment a little bit about the pace of change? You know, we know that some other countries have made this sort of tremendous flip to some of these systems which are value-based, whereas we're going, I think, quite iteratively and quite slowly. Do you think that that will change, or is it the fact that even in very, very different administrations, we still move very slowly? That's just going to be the way America is going to work for the next decade or so.
Yeah, I do think we're at a crossroads, but we still have a fee-for-service system largely, unlike other countries that are more sort of already foundationally based in more global budgets, global payments. So I think that model, there's obviously a lot of politics entrenched in the fee-for-service model, and that's going to make it difficult for it to just go away overnight. But I think this is the most concrete movement we've seen away from it. And like I said, the pandemic might even stimulate that even more, showing that, you know, we can't necessarily go on the way we've been going on.
Because I had predicted this would take place in the last century, which is before our students were born. And I had, you know, set into place some preparations, et cetera, which, you know, were always good because they had to do with emphasizing quality, but may have been a little premature. So I'm curious, and I think that the American public moves much more slowly than a lot of other people wish in this regard.
I see, Andrew, you have your hand up. Did you have a question?
Sorry, my mistake. I did not have a question.
Okay.
Rachel, this is Dan. Thank you very much for that. That was great. I want to ask a couple of fundamental questions just while maybe the residents are still listening. The first one I want to ask is, how does your consultancy firm kind of interact with policymakers? You know, how does that piece work? Because I think that's poorly understood you know, medical schools do not teach about how policy is made very often, and how we as the providers interact with the policymakers. So if you could just give us a little bit about that, that'd be great.
Sure. And I agree that's important, and it is unfortunate that there's sort of not enough time in the curriculum to teach this sort of stuff. But so our firm, it has a legislative and regulatory side. I'm actually on the regulatory side. Some of my colleagues are more traditional, what you would think of as lobbyists that, you know, go to the Hill and try to influence legislation. But once legislation is passed, the legislation is pretty bare bones, even though some of these bills are thousands of pages long. They really are, they don't provide much detail. All the detail gets worked out in the regulatory process, and there are certain rules that the government must follow. They have to provide the public with an opportunity to provide comments on draft regulations implementing these pieces of legislation. And so that's where I come in. So I'm not going up to the Hill and lobbying Congress, but I'm sort of lobbying CMS staff, the administration, and I'm trying to influence the way they decide to implement these statutes into sort of more boots on the ground regulatory policies. So yeah, part of that is meeting with them, phone calls with them. A large part of that is reading through proposed rules that come out. The Medicare physician fee schedule proposed rule came out this summer. There was a public comment deadline that just ended yesterday, actually. So we worked with many of our clients to provide substantive feedback on some of the proposals that CMS is providing for Medicare payment policies for 2022. And CMS will take that stakeholder feedback into account and then issue finalized policies before the year's end, and then the cycle starts over again next year.
Great, that's great. And so I guess from the standpoint of how your firm works, you work with multiple subspecialties with similar interests as regards to managing these kind of regulatory changes and giving those subspecialty organizations input. And so the reason I'm kind of bringing this up is because also not well known that that when you're going to national meetings later on, when the residents graduate, they're part of the national meeting is education, and other parts advocacy, and the advocacy requires financial support, which is typically done through kind of the Washington committee, or depending on which organization you're in, different committees that hire your consultancy firm. Is that kind of correct?
Yes, that's
interpretation.
Correct. And,
yeah,
we do, and we represent a range of different specialties. But I do want to emphasize, I have a public policy background, political science background. I have no true clinical background. So as you were saying, it's really important for the clinicians to get involved and to provide me sort of with information about what's actually happening on the ground and how these policies will truly, affect their day-to-day practice.
Right.
I only can, tell Congress and CMS what you guys tell me. So it's critical that I have that sort of conduit.
Right. And I guess the final point I guess I'm driving to is that, if you're as a physician, if you're frustrated about what changes are being made, sure, it's helpful to vote for one president or another, but it's actually voting and then the behind the scenes management of how policy is implemented are in some ways two different things, as you kind of pointed out in the discussion of the Trump era versus the Obama era versus the Biden era. They make small incremental changes, but that's where the changes are occurring, are not legislative necessarily, but regulatory. Yeah. So anyway, that was my plug.
All right.
For the Washington Committee. I know we have to get everybody off to meetings. Rachel, I'm sure we could talk about this for another hour. At least I could. I don't know about anybody else, but the older you get, the more interested you get in these things. So,
Rachel, thanks very much. It's much
Sure,
appreciated.
for having me.
Take care.
All right. Thank you. Appreciate it.